right, good afternoon. Welcome to today's session titled Minimizing Opioid Prescribing After Surgery. I'm Vicki Wickline. I'm the Vice President of Value Realization at Get Well Network, and I'm happy to kick us off today. So during today's session, our presenter from Northwestern University, I'm not sick, I swear, I'm really not, is going to share his work on opioid reduction initiatives. Opiate abuse is the single biggest public health crisis of our time. It contributes to more than 130 deaths per year in the United States. Our presenter today, Dr. Stolberg, is going to share the results of a standardized survey administered through GetWellLoop to better understand prescribing patterns by procedure and usage, as well as disposal patterns by patients. Now I'm going to introduce our presenter. Dr. Stolberg is a general surgeon at the Health and Services Researcher at Northwestern Memorial Hospital in the divisions of gastrointestinal and endocrine surgery. He earned his PhD in health services research with a concentration in epidemiology and biostatistics and a master's in public health and public policy at Case Western University in Cleveland, Ohio. In addition to his clinical responsibilities, Dr. Stolberg is the principal investigator on federally funded research projects where he studies methods for opioid reduction in surgical prescribing and preventing drug diversion. Dr. Stolberg is also the director of opioid reduction efforts for the Illinois Surgical Quality Improvement Collaborative, which is a 55-hospital quality collaborative with hospitals throughout Illinois. After hearing from Dr. Stolberg, we're going to have about 10 minutes at the end to open the floor up to questions. Before I get started, I'm going to share a disclosure statement with you from the Maryland Nurses Association. The Maryland Nurses Association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. If you wish to receive credit for attending this activity, you must complete this session survey found on your conference mobile app. In the survey, it's important that you check the box indicating that you would like to receive credit, enter your full name and email address in the space provided. Your certificate will be sent to that address. In compliance with the continuing education activity credit conflict of interest disclosure requirements, we'd like to announce that the presenter of this session has no commercial association that would create a conflict of interest. Dr. Stolberg, I'm going to turn it over to you.
Hi, thanks for coming in. We were just laughing and staring at each other because I was in this room right before this learning about all the Lurie Children's efforts, and Lurie Children's is literally across the street from where I work, and I didn't know any of it. So you got to come all the way to DC to learn that your neighbors are doing excellent work as well. So thank you everybody for coming. So that I have some concept of who's in the room and what your background is. How many folks in the room are actively working on opioid reduction efforts? Okay. How many people are doing that in a surgical field as opposed to medicine? Okay. How many people are focused on inpatient only? All right. And how many people are doing outpatient only stuff and or both, I guess? Okay. So a little bit of everything. All right. So hopefully this isn't too much of a duplication. As you can see, I do a lot of opioid work and a lot of opioid reduction work as it relates to surgery, and the work stems back to about 2016. So before we get started, I have two disclosures. One is that I have a grant from PACERA, so not related to this, but I do have one, and I do some consulting work where I teach hernia repair through Intuitive. But all of us are in this room because the headline was talking about opioid reduction and the opioid crisis. And I think one of the big things that we all have working in opioid reduction as it relates to surgery is trying to figure out how this big number, which is all over the headlines, right? This is why we're all here, this rapid rise in deaths. How does it at all relate to the surgical field? And so I'm going to give you my take on that and how I think we, when we're trying to do opioid reduction efforts related to surgery, are trying to make a difference in that. So national drug overdose deaths have been rapidly rising since early 2000, with really a pretty rapid uptick between 2012 and then 2017. The 2018 data should be out soon, but we're talking about 70,000 deaths. And the reason really this is all over the headlines is that if you look at something else like motor vehicle accidents, we made a lot of progress in the 80s and 90s with deaths related to motor vehicles, and it's essentially been stable. I used to draw the actual line out there and it was kind of confusing. It's essentially stable at about 40,000 or less deaths per year. So right now, deaths per year from drug overdose double those from motor vehicle collisions, which is really a shocking statement. But the astute person would say that's all drug overdoses. That's not necessarily related to opioid. But the entire uptick in drug overdoses is captured by overdoses related to opioids. So if you look at overdoses related to opioids, you'll notice that curve looks very similar to the curve that we just saw in the increased deaths. So, okay, so all the popular media, the scientists, everybody's telling you this overdose death is related to increased overdose deaths in opioids. But the next thing that you hear all the time is IV drug users, right? And heroin and all these other drugs. It's not prescription pills. They talk about multiple waves and things like that going on, right? But if you look at the data for prescription writing, what you'll notice is that even if the individual who overdoses isn't directly dying from a pill, somehow that rise in overdoses was associated with an equal rise of the same rate in the number of pills that we prescribe and the number of deaths related to pills. And to demonstrate that, if you just take out all the other noise and you look at opioid sales and you look at prescription opioid deaths, we talk a lot about how association does not equal causation. If you go and study this, and many of you I'm sure have advanced degrees in various areas, right? If you do your master's in epidemiology, one of the criteria is when you remove that inciting event, things get better or the effect goes away. So not only do you see a rise, but you start to see as it plateaus and as the prescriptions start to go away, those deaths related to those prescriptions also go away. And I've presented this a lot. This is data that I've been presenting since about 2015, 2016 when I started working in this area. And I gotta say, I talked to mostly groups of surgeons. And most surgeons will at this point tell you, I have treated surgical patients for 25 years. I've given the same prescriptions for probably that entire time, and none of my patients die from prescription overdose deaths. You're wasting my time. And it's not that they disagree with the population, but it must be related to chronic opioid pain prescribing. It must be related to outpatient medicine prescribing. It's something else because they don't see it in their patients. And so I think it's really important to think about what our patients see. We're talking a lot, right? I stayed purple, Northwestern, but also the GetConnected, right, conference. It's important to bring it down and look at it from the patient perspective. And actually, this is what got me interested in the opioid crisis to begin with. This patient is actually my mom. And after I wrote a small foundation grant, I got some money, I said, I'm studying the opioid crisis and trying to figure out how it's related to surgery. This was in the summer of 2015, and she says to me, by the way, she's in Cleveland, Ohio. That's the middle of the Rust Belt. It's literally the cover of the Cleveland Plain Dealer almost daily that more and more people are dying of opioid-related deaths. And she said, well, you know what? I've had a couple surgeries this year, of which I didn't even realize. But she went in and she had a thumb surgery on March 23rd. Now, if you know anything about pain management and thumb surgery, they did the entire thing awake. They had this old drape from like her shoulder down. There was a blue curtain up. She said, her words were, I remember the entire thing, including the surgeon asking me to please be quiet. So she literally talked and was awake the entire time, and she didn't feel a thing. She had a block in her arm, okay? So the entire surgery had like an ERAS pathway, right? It had a pathway built around minimizing opioids and pain management around the time of surgery, and she left a couple hours after the surgery was done, and she was given a prescription for 30 Percocet. And she was given the instructions, you don't hurt now because you have local anesthetic on board. Your hand is all numb. It's going to start to hurt. Go to your pharmacy, get the prescription, take your pills before it hurts because you have to get in front of the pain. Okay? So that was March 23rd of 2015. And that would be fine, except that as most people do, she said, I've been putting off getting this thing done for my tooth. I had to get one pulled and a post put in, and it was expensive. And I figured, I'll just bundle everything. So 3 weeks after her thumb surgery, she goes and she has a dental procedure done where they kind of take out a tooth and remove it. She says she didn't talk through that, but she still remembers it, right? She's got to be awake. She's not intubated. This isn't a general anesthetic. Same thing happened. She left after that dental procedure. It doesn't hurt much right now. You're going to drool. We gave you a lot of local anesthetic, but take the pills. Make sure you get in front of the pain because it's going to hurt. And that's fine, except she had to get her bunions taken care of, and she'd already met her deductible. So she had this toe procedure, thing on her heel, a thing on her big toe. Again, she was awake the entire time. She remembers the entire thing. She was blocked from the knee down, okay? But at the end of that, they give the exact same patient instructions. Pick up your prescription, get your pills. So in the matter of, 3 months? In a matter of 3 months, I'm meeting with her on July 4th. That's why I was with her. It was the July 4th weekend, and I was back in Cleveland visiting. She had 90 pills prescribed. How many pills do you think she took? As a wild guess. How many people think 60 to 90? Okay. How many people think 30 to 60? All right. How many people think 15 to 30? All right, I think we're getting close to a majority of 15 to 30. How many people think 5 to 15? All right, there's where the most people said. How many people think less than 5? Nobody. Okay. She took none. So what I love about this story, and the fact that I've told it so many times now, is that there has been an incredible shift in our understanding of how many pills patients take. The first time I told this story was the American College of Surgeons. It was a big room. Not a single hand came up for less than 15, and the overwhelming majority thought 60 to 90. So our perceptions around what people actually take after procedures has changed, and you can just see that as you go around the room. And the little known fact is that she was a nurse her whole life. She was a little bit worried that she wasn't going to sleep well, or she might get nauseous if she took her Percocet, so she decided to take Tylenol instead, went to bed, woke up the next day, didn't hurt enough that she did anything else for all 3 of the cases. However, she was told by a doctor to fill her prescription, so she had 90 pills sitting in her cabinet. So even though she didn't take it, she had 90 pills. And then I was like, well, why do you have 90 pills? She's like, they told me to pick them up. I picked up the pills. So this has now been repeated, and the data supports that this happens over and over again. This is one of the first studies. This was in an orthopedic procedure. On average, when you look at an entire patient population, the majority of patients actually take between 0 and 5 pills, and this is after orthopedic hand procedures, okay? And you can see there's this distribution like this. It turns out if you do this across multiple different surgeries, general surgery procedures, thoracic surgery, vascular, the curve always looks like that. There's a peak in the beginning and then it goes down. It's just where that peak is and how many pills on average people are taking. But there's always a taper. If you give 60 pills, there will be a taper of people who take 60. You give 90, there's a taper of people who take 90. In the data I'm going to show you, there's some people got 160 pills. I have a feeling there are some people out there that would take 160 pills because they were told to take them. So now, if you look across multiple surgical specialties, orthopedics, urology, dermatology, all of these surgical specialties, if you ask how many people had unused opioids after surgery, patient-reported unused opioids after surgery, 70+% of people have unused opioids after surgery. So the majority of pills that we prescribe go, like my mom's story, into the medicine cabinet and they aren't used, okay? So that would be okay if everybody knew, hey, these are dangerous. They're dangerous for our kids. They're dangerous for our pets. They're dangerous for our neighbors. There are open houses where people go to open houses just to steal them out of folks' medicine cabinets. They're dangerous for our society. So as soon as I know I don't need them, I'm going to throw them away. Well, if you ask people, nobody throws them away. Turns out about 4% across most studies throw them away in an FDA-approved manner. Now some of the studies suggest a little higher. We'll show some data on that in a bit. And last but certainly not least, if you now ask people who are abusing pain meds, okay, so if you ask the folks who are using these meds inappropriately, where did you get them? All you need to know about this slide is gray says, what do you mean? They're just available in society. I get them from friends, family, I borrow them. That's how I get them. The gray line over and over again. The majority of patients, and it's over 50%, somewhere around 60 to 80% of non-medical use of pills are because they're readily available in society. So I think it's a rather short leap to say if surgeons are prescribing too many pills or more pills than the patients are actually using, and the patients are not throwing them away, then we have a lot of pills available in society, and the single biggest way in which opioid misuse occurs is because they're available in society. We are causing this, we're part of this, and we have to be part of the solution. And so it's recognizing that it may not be your individual patient, but you're treating that patient, you're treating the family, and you're treating the community. And you can cause harm not only to the patient, but to the patient's family and the patient's community. And getting the patient to understand that and getting physicians to understand that is really important. So much so that 40% of all overdose deaths in 2016 still had a direct link to a prescription. Now these could be, they had a prescription med on board and other meds, but that is a shocking number. It means that we still have a long way to go to get pills out of our society. And one of the saddest statistics that you'll read out there is that the CDC does surveys of folks who have overdosed and are in emergency rooms. So if you ask individuals who have overdosed and are using from heroin, 75% of them got their start by abusing pills. So even if the pills themselves don't kill people or cause harm, or they're able to get off of them, 75% of those folks who go on to heroin started with those pills. So it's a gateway to other drugs. So with that, this was our first grant. It was minimizing opioid prescribing and surgery through National Institute for Drug Abuse, NIDA, through NIH. What we tried to do is reshape the culture around surgical prescribing, set better expectations, risk screen our patients so that we know which ones are actually at risk for overdose, at risk for chronic use, at risk for chronic pain. Family members have risk. Changing the conversation around pain management to be about optimizing function. I want to limit your pain so that you can participate in your healing. I want you to be able to get up, walk, take deep breaths, and participate in your healing. And I want you to be able to do that comfortably, but I don't want you to do it pain-free, because then we may be masking something, we may be over-treating, and if we treat too much of the pain, then what can happen is people underbreathe, they can overdose, they get blood clots because they don't walk, all sorts of problems. So we talk about it in optimizing function. We want to manage the pain well enough that we can optimize your function. One of the things in kids, we heard earlier about kids, when you manage their pain, they're kind of happy and they go about their day, right? And you don't, they're stiff and they don't look well and they're just sitting there and they're miserable. Adults, sometimes they look miserable even when you're treating their pain. So it's a little bit more difficult to sometimes understand, and we really struggle with how do we get pain scores? How do we figure out how to and so what we do is we talk about optimizing function. We don't talk directly about the pain. Last and certainly not least, we need to figure out a way to better monitor use. We not only need to prescribe fewer, but how do we know how many to prescribe? How do I know how many to prescribe to one patient versus the next patient? How do I know for one procedure versus another procedure? All these things may vary, right? People come in with chronic pain. They come in with anxiety. They come in terrified of opioids. They come in with all of their own things, and if we don't know how many they're using, how do we know we're treating them well? And last but not least, everybody in here said they're working on inpatient or outpatient, things like that. It has to fit into everything else we're doing. Everybody has ARS pathways and everything else. This is comprehensive. It's supposed to be about a way in which we manage patients and not just one program that works in isolation. It's for any procedure, for anything we do, and it can fit very nicely and envelope around your ARS pathways or other things. So one of the hats that I wear is I sit on the opioid task force for the American College of Surgeons, and we had come up with patient education materials. We had come up with guidelines for prescribing for physicians. We had done all of this work to help our constituents. And I, in my own practice, was using HealthLoop. So back 4 years ago when I first met Vicki, it was called HealthLoop before it became part of the Get Well Network. And I said, this could be an incredible platform not only to improve my patient care, but for me to start to understand use, because I want to know how many pills my patients are using so I know how to prescribe to them. And so you all know about the loop, so I could do this rather quickly, but it allows for daily push notifications, secure messaging between patients. I can add in the education that I want and customize it so that I can now use. We never had pain management guidelines in surgery. That didn't exist. So American College of Surgeons says, okay, now we have some. Now you got to integrate that. You got to get up with the times. There's new education material coming out all the time, so I can put that in. We can set reminders, and we can get patient-reported outcomes longitudinally. On the provider side, there are a lot of benefits, and I'm sure you guys all know about these too, but I've found that I can manage my patient population. I can look at, say, all my minimally invasive inguinal hernia repairs versus my open inguinal hernia repairs and understand the differences between those. And I can do it sort of in real time. And I can download the data and look at it myself, which, as a nerd, I like to do. So that's my data. So I went to the American College of Surgeons, and I said, I'm sitting on this task force, and this is what I'm looking at. This is my patient population over the last 2 years, as of 2016 to 2018, this is what my patients looked like. 89% of my patients were reporting their patient-reported outcomes. Over time, that was 100% pre, and then you can see it varies a little bit, the 2-week, the 1 month, I don't know which ones I have up there. It's a little blurry for me, but you get the idea. And I could draw pain curves. So I said, look, I know how much pain my patients are having. I know how much opioid use they're currently doing. Can we do this for all the providers? Can we say this is supposed to be enveloping of all procedures? Can we roll this out across the country? And with HealthLoop's help, at the time, Harry and Vicky came and talked with the American College of Surgeons and the Opioid Task Force with the American College of Surgeons, and HealthLoop in conjunction came up with essentially what was supposed to be ongoing quality improvement project for the country to help utilize a platform that already existed, take standardized recommendations, add them in, collect data, and give it back to the physicians in real time. That's it, right? Just take what I had already been using and open it up to everybody. You can have an ortho pathway for knees, and that's fine. We just want to know this is standardized information about how to think about pain. This is standard information about how to use your pain meds, use alternatives, and then gather information about use and how people are doing. And hopefully people would rapidly iterate, right? I mean, this is for them. It's for our users, for our providers, and for our patients. And so the way I think about it is this. This is me, my picture, I guess, in there. And this is what the patient sees, right? And this was a way for me to say, I was struggling with how do I create that loop? How do I create the prescriber to patient loop with putting opioids in the middle? And so we leveraged the platform we were already using. As of now, it's been almost 2 years that the project has been live. We're going to spend the rest of the time, I'm going to tell you about how it went and what we've done. But it's a standardized loop. Over 8,000 patients have now enrolled. They get real-time data back to the physicians on number of pills, MME, pain, and disposal method. And Dr. Benjamin Rossner, who is not with GetWellLoop anymore, but was part of HealthLoop, helped me design this and did a great job with it. So pain management, patients enrolled based on procedure type. Okay, there were certain procedure types that certain docs did not want, but each location was allowed to choose whether or not to participate and to sign up. They get their SMX triggered smartphone app. The baseline preoperative survey gets at chronic pain usage and PROMIS pain interference. PROMIS is patient-reported outcome measures, and pain interference is a standard way of measuring patient-reported pain measures. And it got triggered on post-op day 2, 5, 9, 14, 20, 30, and 60. So that's important because if you're thinking about it as a research effort, that makes things really tricky. Because you've got all these data points at different time points and people answer at different things. But if you're thinking about it as a quality improvement effort, that's the data you need. And so it's important to remember that this really was meant to be a quality improvement effort and feasibility to see if we could do it and it would benefit patients and physicians. So there are the actual numbers, 8,748 patients as of December 2019. 54.2% of them were female, average age was 61. 1,000 of them, or 12%, were chronic users of opioid prescriptions. So that's important to know, right? If 1 in 10, and in certain practices it may have been closer to 1 in 4, as 20-25% of patients in certain practices come in chronically using opioids. Baseline preoperative survey was completed by 83% of them, and the postoperative survey by about 96.7%. So pretty darn good response rates. As a researcher, I never get response rates like that. So GetWellLoop is certainly onto something. These are the enrolled patients by states, a lot of users. You can see in the first 2 states, Wisconsin and California, and then tapers off, but it was across 5 states. Here are the top procedures that collected data and are using it, a lot of orthopedics. It just is reflective of where GetWellLoop currently is in practice and what people are using. We're not sampling. This isn't something that I'm driving. This is driven by the users. So knee arthroplasty was the most common, followed by hip replacement, and then lumbar spine fusion. So that's important to keep in mind as you start, you'll see the data on prescribing. When we look at types of opioids, it's all over the map. People really do prescribe all sorts of different opioids, which I was very surprised by. Our data in Northwestern is, really only one of two meds. It's either hydromorphone-based or oxycodone-based. So it does look like across the country, practice patterns really do vary, and a lot of people use different meds. But the majority is still oxycodone or hydrocodone-based. Postoperative opioid prescriptions. We had 4,535 patients who participated in the postoperative survey with regards to their opioid prescribing. And what that meant was that 84% of patients told us whether or not they received a prescription and received one. That is on par with a lot of the other data that we see across Illinois and across Northwestern. Somewhere around 80 to 85% of patients in the current state get an opioid prescription after their surgery. So that's fascinating. You're going to see people got 140 pills. Some people are getting 140 pills. Some people are getting 0. So there's a lot of individual patient variation within the data. 369 had non-prescription over-the-counter medications that they had in addition to this. This is a big area for improvement. 100% of my patients get non-opioid pain management strategies prescribed to them. It is written in their discharge. It is told, this is what you do first. And I think that needs to be part of our next culture change, right? There's no reason people can't use ice. I mean, that is a non-opioid strategy. And for most patients, there's really no reason they can't use Tylenol, acetaminophen. And I know some of the orthopedists don't like using the NSAIDs, but if they're, if they do, they can use it. Some don't mind. And if they're non-orthopedic procedures, they can use this. So really, there's some low-hanging fruit in some areas we can do a lot of good. There's a lot of variation by provider. You can see some providers averaged way over here by 60 pills, and other providers averaged way down there by 20 pills. So a lot of variation by provider. But what I was most interested in is trying to figure out procedure-specific guideline recommendations, right? What we don't have and what we need as prescribers is, well, if I'm doing a knee, how many pills do I give someone? If I'm doing a hip, how many pills do I give someone? And this is the first look at what we're of that type of data. So if we group them into procedures, you can see lumbar spinal fusions all the way on the left. It's just organized by most to least. What you can see in the gray line is the max number prescribed as a standard prescription. So that would be 10 plus prescriptions of that amount by that provider, right? So that's just their standard approach to that procedure, lumbar spinal fusion. That dark blue represents 80th percentile of patient use. Okay, so let's wrap our mind around this just real quickly because we did a lot of thinking about this. If you're going to go to a surgeon and tell them, look, half of your patients use 15 pills or fewer, prescribe 15, they're going to go, no way. That means 15% of my patients have too much pain and they're going to be left with no alternative and they're going to be calling my office for refills and they're going to be suffering, right? So you have to come up with a number that isn't the median. By the way, the median is the light blue. You have to come up with a number that says, look, this percentage of patients would use this amount regardless of what you prescribe. So if you're prescribing 125 pills, it doesn't matter. 80% of the patients are using this number of pills or less. So for lumbar spinal fusion, that's 40. So you got to ask yourself, why would you be prescribing 125 if 80th percentile is 40? And so what we're working towards is maybe we can help set number of pills prescribed by the 80th percentile and just do that by procedure. Here it is for excess opioid pills by procedure. You can see the number of pills, a lot of excess pills by procedure. And then here's where we get really granular. So the idea is here are the majority of the procedures that we have across the various loops, and the gray line, the light blue line, and the dark blue line. Unfortunately, those blues switched. I don't know why, but the larger number is the 80th percentile. And what we're going to be recommending once we are really sure about the data and clearing it is that what we can do with this data is set procedure-specific prescribing rates, right? And you just say 80% of patients or fewer will use this much. Use that as your default. And you shouldn't see an increase in your number of refills. You shouldn't see an increase in the number of patients that are suffering because they didn't have enough pain control. And you can also see, very interestingly, we're starting to get a glimpse into some people for, looks like down there for ventral hernia, on average are prescribing too few. So what happens there is that then patients are calling for refills. So refill rates go up when you're prescribing too few. So we want to find that sweet spot where patients are adequately treated for their pain and they don't have leftover pills. Here it is for opioid use for chronic users. So these are the people who came in with chronic use, and here's for non-chronic users, and I think it's important to divide by that. I think we're almost out of time, so just real quickly, we have data that suggests people still don't throw away their pills. So the numbers are getting a little bit better, but they still suggest patients aren't throwing away their pills. And what we're really trying to do here with this whole initiative is to change culture. Manage pain proactively, use multimodal strategies, use opioids only to treat excess pain, incorporate a conversation on opioid use into all pre and post interactions, and we can leverage technology to do all of these things, and then normalize disposal of unused opioid pills. And so those are really the targets of this type of initiative and of opioid prescribing in general for surgery. And since we went through all the effort of getting this video, and I always like to end before questions with, I could give the patient the last word after questions. Why don't we do that? Okay, so questions. Yeah. Oh yeah, sorry, here, use the mic.
Hello?
Yep.
I don't know which one yours is. So I am a spine program coordinator for a 75-bed hospital. We've got 4 spine surgeons and looking at reducing opiates, and these slides are awesome, but none of my spine surgeons are here today. Can we have access to these slides? Absolutely. Is there a way I can get a copy of them? Cool. Super easy.
And do you guys use?
We don't use Loop, but we Joint Commission certified for spine surgery. We also have a Joint Commission certified program for orthopedic surgery, and the orthopedic associate group has 2 of my spine surgeons and multiple orthopedic surgeons, and they have it. But we haven't integrated it into the hospital yet, so we're looking at doing that. So this is huge. Yeah.
Yes.
Thanks.
Thank you. What is generally the reaction to this when you present this data to your fellow surgeons?
They usually shrug and go, okay. And they just choose they're like, if you make a convincing argument to tell them, look, your patients are not suffering, you are not gonna have increased calls, you're not gonna have refill requests go up, it's going to be okay. Then they're like, okay, what's the number? And they prescribe it. Yeah, so prescribing rates across Northwestern basically changed in a matter of a month. And the areas where it didn't were the people who didn't come to my talk or those types of things. And we just saw it in the data and wrote them an email. And people who don't come to the talk tend to have a harder time putting it all together. People who I just send the slides, actually, they're often flip through it and they're like, I don't know if I believe it. So I don't know what the difference is, but Dartmouth was a real leader in this, and they showed that by a grand rounds, they changed prescribing by 70%. Michigan has now shown the same thing. They basically do visiting grand rounds, and the folks, Chad Brummett, who's an anesthesiologist at Michigan, goes around and talks about opioid prescribing, and then the surgeons who show up are like, oh, okay, and they change. So I think this is a topic that, most surgeons, all surgeons that I've ever met want to do right by their patients. They just don't feel like they have actual evidence that we know what we're talking about when we say change this or do this. And they don't want to be told what to do. And so if it seems like they're not being told what to do, instead they're saying, you're saying, pick your number, but we suggest 80th percentile, and they're like, okay. By the way, we post all of these online through our website. I can show it at the end. It's just isqicisquic.org. And all of our recommendations update quarterly. So when we have use rates through the system, we update it. We have general surgery, gynecology, thoracic, and orthopedic procedures currently. Yep. There you go. Yeah, and Loop members have access to their own data and their practice patterns, and so, yeah.
She's got a question.
So how have you involved the other team members, so other than surgeons, in this process?
Which part of it?
The patient education, patient to reinforce the things that you're talking about, and are they involved in the health loop piece?
Yeah, so we actually have training modules built for pharmacists, for nurses, and for prescribers. So prescribers include nurse practitioners with license to prescribe narcotics, and for surgeons, which we make freely available. They're on our website. You can watch them there, or we give them for free to introduce into your learning management system. So it's currently in 14 different hospitals in their learning management system. They get CME credit for it. We also have implementation guidelines that we give out for free, and so you have handouts that say, if you want to change prescribing in your practice, here's how you do it, and has PowerPoints where I narrate stuff and all sorts of material. So I'm happy to share that website, and just go to download it and shoot us emails. And I should switch to this. I don't do this alone. Okay, I have an army of people behind me: statisticians, project managers, project coordinators, public health folks with a master's in public health, and they are constantly helping update the guidelines and push out more implementation work. And this is one of many opioid-related reduction things in surgery that we're trying to do. So.
Through GetWell Inpatient, we launched an opioid pathway last year that does allow you to do some of the education for the patient within the hospital based on similar guidelines. And so for those of you who haven't seen it yet, that's an option for the patient education piece.
The patient education pieces are also built into the app. So they're also, things that are part of the loop that give them some of the stuff like talking about it in terms of, but we have how do you set patient expectations as a guide. It's a downloadable 3-page thing that talks about how do you talk about patient expectation. There's an educational video module that we built that teaches you how to do patient expectation setting. And you can watch it and get CNE credits or CME credits. Yeah.
Is there any similar data for pediatrics?
Yes. Mehul Raval, who just started about a year and a half ago at Lurie Children's, is replicating all of our work and just got an NIH grant called Popsicle. Do you guys know? I believe the acronym is Popsicle, but the data will be coming. So he is also trying to replicate a lot of this work through pediatric NISQIP and through a collaborative of multiple pediatric hospitals. If you email me, I'm happy to connect you.
Thanks for the talk. I love seeing the data and talking about this more. Two-part kind of question for you. Do you think that we will ever get to a point where we start empowering the patient to say no? I know that I myself have refused narcotic prescriptions. I just don't, Motrin is great. You know what I mean? Do you think we'll get to a point where we empower the patient to say that that's not what they need versus being told what they need? And then my second part of the question is, do you ever think we'll get to a point where we could just change this to not prescribing at all post-op? I mean, is that something, do you think that's feasible, or is that just so innately
yes,
ingrained?
Question B, no.
Right,
So
okay.
that's the very short flip answer, but the reality is that patient expectation setting is about empowering the patient to take control of their own pain management. And it's about teaching patients how to layer on non-opioid medications and then know that they're there as a crutch if they need them. And but to do all those other things first, and to understand that they shouldn't be pain-free, that discomfort is different than pain, that the point of the medication is to help support their healing and to help in their recovery. And I think empowering patients is a critical part of talking to them preoperatively about all sorts of components, and I think pain is part of that. So thank you for that question. And the second part, I would say some surgeries should be opioid-free now. We're doing trials in open inguinal hernia. My robotic inguinal hernias and robotic choles and lap appies, none of them get opioids now, except in select patients, ones who are chronic using, ones who have low pain tolerance, people who request them and stay in-house, those types of things. But there are certain procedures that can be opioid-free now. I don't think shoulder arthroplasty will get there anytime soon. Maybe at some point, but it's just really painful and has a long duration of recovery. So there you go. So if you look at the shoulder arthroplasty data, somewhere around 20% of patients don't use any. So what's different between the 20% of patients who don't use any and the 20% that use 160 pills, right? And so I think that there's a lot of individual patient characteristic components, how we perceive pain, how we manage pain, pain tolerance, all these things that we really just don't know a lot about yet. And so it's important to get information to the physicians. It's important to have guidelines, but it's also important to recognize everybody's different. Yeah.
We've got time for one more question.
All right, last one.
Great presentation.
Thank you.
One quick story and then one other question or alignment. When I was a CIO at a health system in Western Massachusetts, we met with the DA, and the DA asked us one question: do you know who the biggest drug dealer is in the county?
Mm-hmm.
He said, you guys are at the health system. This was 2005. The second thing
Getting an
is
award
that
for it, or?
yeah. The second thing is, I think you hit the nail on the head about the culture change, because one of the efforts we have underway at Bay State with Dan Engelman, I'm not sure if you know him from the cardiac ERAS group, is development of an MME app that they can actually see the opioid use post surgery, and changing the conversation at the bedside during rounds. It's been tremendous, and we've been the work that he's done with a couple of other folks has been fantastic.
That's
so I love to
fabulous.
connect. I'm sure you guys are connected already, but I'd love to continue the conversation.
No, I mean, I know of some of his work, but I'm not directly connected to him. And I think it's really important for physicians to have the data, know what it is, and I think it just wasn't part of our culture to measure it, to think about it. We just wanted to make sure people didn't have pain. With that, I always like to try and give the patient the last word, so if you'll humor me, this is just a real quick video, if it plays.
It's unfortunately easy for my brother, Danny, to become another statistic. But it's important that people understand that he had a life, he had a family. We're forever changed by his loss, and he's not a statistic. He was my big brother, and I miss him.
So she's a nurse manager who works in our opioid reduction efforts at Delnor Hospital, and was brave enough to videotape that and tells her whole story on our website. Her brother was a construction worker. He was he was a family man. He had 2 kids. He fell off a ladder, broke his back, had 3 subsequent surgeries, never really got pain-free, never really got his job back. Tried to come off of the meds completely, and was working with a physician to come off of them, had gotten rid of all of his meds. He was off of his opioids completely for several weeks when he was trying to get back to work and tweaked his back, and he had some pills left over. So he said, oh, well, I'll just take some of these. Well, after years of being on narcotics, he was on very high doses of oxycodone. And so he took a few pills that would have been fine for him 3 months earlier, but since he no longer had the tolerance, he never woke up. And it hopefully motivates all of us every day to understand that there is a human suffering side of this, and we may do a surgery in 3 hours, but these folks live with it for the rest of their lives. And so as you go forth and you continue to do this great work, please just keep them in mind, and thank you everybody for coming.